So welcome to this side event, Protecting 1 Billion Hearts, partnering to accelerate access to blood pressure lowering medicines, organised by the World Heart Federation and Resolve to Save Lives. This evening, we're going to be focusing on the critical role that hypertension medicines play in reducing cardiovascular mortality, but also the barriers that hinder their availability. That's really important because, as our title suggests, there are 1 billion people globally who have hypertension, but only 21% are controlled. And the burden, of course, as always, falls on low and middle income countries. So this evening, we're going to start by having 2 high-level presentations from Resolve, followed by an overview of a success story in the Republic of Korea, which has gone from being a country which was amongst the highest in the burden of hypertension to being a regional exemplar. We'll then highlight some country experience from Qatar by video and also from Bangladesh and Ethiopia in person, covering their successful policy interventions and innovative financing mechanisms to get these important medicines to the people who need them. We'll also be hearing from the patient perspective from Zambia and the impact of not having these medicines financed. To introduce myself, I'm Jackie Thornton. I'm a health journalist for The Lancet and the BMJ in the UK. You'll be hearing more from me later when I moderate our panel discussion. There will be time for questions from the floor, so please do keep those in your head for later on. There'll be a cocktail reception afterwards, which you're all cordially invited to after the proceedings. So that is our agenda for this evening. First, I want to hand over to a man who needs no introduction, Dr. Tom Frieden, who is President and CEO of Resolve to Save Lives, who will give us some opening remarks. Thank you very much indeed, Tom.
Thank you very much, Jackie, and thanks to all of you for being here. I also want to recognize many of the people here, Dr. Jagat Narula, President of the World Heart Foundation, our own staff member, Bolanle Banigbe, who is the director of our hypertension program. You'll hear from Dr. Hyun Kim, and really, really impressive progress in Korea, an inspiration for the world. Delighted to see our longtime friend, Dr. Mebratu Mesebo, who will talk about the experience in Ethiopia and the real progress. I've been there many times. I've seen the huge potential, but still what's needed in terms of solidarity and development. I also want to thank, he was here earlier but couldn't stay because he had to be at another event, Sheikh Dr. Mohammed bin Hamad Al Thani, who's Director of NCD Prevention Programs at the Ministry of Public Health in Qatar. He'll have some recorded remarks. And delighted to see my old friend, Honorable Special Assistant Dr. Mohammed Syed Rahman from Bangladesh. We're really excited at the potential that Bangladesh has and the quality that they've shown, a tripling of control rates and a 20-fold increase in the number of patients controlled in just a few years, community-focused, great information, clear, but a real challenge with medication access, as we see in Ethiopia also. Also, I'm so delighted that Brenda Chitindi is here. We need more Brenda Chitindis in the world. Advocates for patients with heart disease and stroke, advocates for people who don't have to have heart disease and stroke if they get treatment that can cause as little as 1 cent per day. Hypertension is the most neglected condition in the world. It accounts for nearly 1 out of 5 deaths, of every 5 deaths. Every year around the world, hypertension kills more people than all infectious diseases combined. Hypertension kills more people than COVID killed at its deadliest and kills people at a younger age than COVID killed them. And yet, despite causing nearly 1 out of 5 deaths, it gets less than $1 out of $1,000 in development assistance for health. This is the world's most neglected condition. Now, I want to tell a story. I'm, by training, originally a tuberculosis control doctor. And there was one moment that changed my life. I had been working on tuberculosis control for many, many months, very intensively. I put in charge of a huge outbreak of multi-drug resistant tuberculosis in New York City. And Carol Stieblo came to visit, and he asked me a single question that changed my life. He looked at this booklet we had written on all tuberculosis cases in New York City in the previous year. And he said he actually went back to his hotel room and he studied it. And when he came back, he said, I analyzed this book, and he pointed out some epidemiologic trends I had missed, which was pretty annoying because I had written the booklet. But then he asked me the question that changed my life. He said, Dr. Frieden, last year, you, in your program in this city, you diagnosed 3,811 patients. Yeah, and this book tells me all about what kind of TB they had and where they were from, and it doesn't tell me how many you cured. And I was so ashamed. It was an obvious thing, but I had missed it. And we're missing it in hypertension. How many people have their blood pressure controlled? Globally, the best estimate is out of 1.3 billion people in the world, the deadliest disease in the world, less than 270 million, less than 22% have it under control, which means there are 1 billion people in the world today, every second of every day, their heart is beating dangerously. It is risking a heart attack or stroke. It is pounding against their arteries in their brain, their heart, their kidneys. It is the world's most neglected condition. We will not reach Sustainable Development Goal 3.4 without better prevention and treatment of hypertension. We've seen huge progress in Korea, very inspiring. And you know, they're very shy and humble. They also made a lot of progress on sodium, not enough, but a lot. And we had to really bend their arms for them to write it up and show it. So we really think Korea can be global leader in hypertension control. We know that globally there are two main barriers. The WHO heart strategy, and I appreciate Slim Slama and Taskin Khan being here, real leaders from WHO, and Bruce Neal from the George Institute, great colleagues in this area. What we've seen globally is that the 5 components of heart are essential: protocol, medication access, team-based care, patient-friendly services, good information system. But the 2 that are hardest, that we see the least progress with, are medication access and information systems. And with medication access, it's a combination of not enough money in the healthcare system and charging patients. And we know this is a route to failure. We don't charge patients for their tuberculosis medications, or their HIV medications, or their immunizations, or their oral rehydration salts. And that's how we get public health success. We will not get public health success charging patients for their medications. And we've seen countries around the world make really good progress providing validated blood pressure monitors. In Bangladesh, they use scarce government resources to buy validated monitors and provide them to many of the facilities. In India, they have free medications for patients and amazingly cost-effective medications, less than a penny a pill, even for some of the latest medications. And we know that this saves money. We've had a wonderful partnership with Ethiopia. We know they can do it, and they'll save money in the long run. They'll prevent heart attacks and strokes. They'll reduce disability. The estimate is $18 return on investment for every dollar invested. The problem is they don't have that dollar now to invest in the medication access. The information system is fixable. We've come up with low-cost, highly effective ways to do that. We know what to do. We need to get it done. We've launched a call to action. All of you have this on your seats. QR code it, sign up. We want a global movement to get the pressure down, a global movement to say it's no longer acceptable that 1 billion people don't get the treatment that has been standard of care in higher income countries for a half a century. It's no longer acceptable that more than 10 million people die every year. most of them because they didn't get a penny a day treatment. The estimate is if we can get to a 50% global control rate, that will prevent at least 76 million deaths, 150 million heart attacks and strokes, and millions of patients who need dialysis for the rest of their lives over the next 25 years. So please sign on. I want to thank everyone for participating. It's exciting to see a growing momentum. This needs to be the start of accelerated global control so that when we're asked, hey world, that Steve-Low question, how many of them did you control? It's no longer 1 out of 5. It's at least half, or as in Korea, 60%. Thank you all very much.
Thanks very much indeed, Dr. Frieden, for that rousing call to action. And I repeat that, please do use your QR codes and sign up. So I now want to introduce Bolanle Bunigbe, who is, as Tom said, the Director of the Global Hypertension Control at Resolve. And I think you're going to give us a presentation. So thank you very much indeed to expand on the burden and treatment challenges for hypertension.
Jackie. Hi, good evening, everyone. Thank you for coming. It's lovely to be with you and to talk about what we can do together to protect 1 billion hearts from the complications of uncontrolled hypertension. You've heard a lot that cardiovascular disease is the main driver of non-communicable disease deaths. 17 million of the estimated annual 41 million deaths due to cardiovascular disease due to NCDs is from cardiovascular disease. And high systolic blood pressure is the most important risk factor for cardiovascular disease. Every year, 10 million people or more die from uncontrolled hypertension. And according to the last global hypertension report, we're not doing very well on hypertension control. More than 1 billion people have their blood pressure not controlled. And we know that 80% of the people with uncontrolled hypertension live in these 25 high burden countries. So we know where we should be focusing attention as a global community. We also know what works. The WHO HART's technical package, 5 simple components: standard treatment protocol, reliable drug supply, team-based care that uses all appropriately trained healthcare workers in the system to participate in hypertension treatment, patient-centered services that make services convenient and affordable to patients, and effective information systems that produce real-time actionable data. We also know that HART is scalable and effective. Since 2018, when it was launched, it has been implemented in 40 countries around the world. The HART partners have put more than 35 million patients on treatment, and with this, we have prevented more than 500,000 future cardiovascular deaths. It is not just effective and scalable. Should be the pathfinder for hypertension control that all countries are investing in, because it is simple, it is scalable. Countries can start quickly, we can learn lessons along the way and use those lessons to improve the care that we provide. The systems that we set up for hypertension control, like patient tracking, promoting adherence, these systems are also necessary for other chronic diseases. So it really serves as a platform for integrating primary care amenable NCD. And finally, it is the return on investment is one of the highest for public health interventions. For every $1 that we invest in hypertension control, society gets back $18. So what is standing in our way of global hypertension control? We have a medicine access crisis. Medicine availability is low, especially in rural areas, in public facilities, and in primary healthcare centers. Medicines are also not affordable. Low and middle income countries, people living in those countries pay at least 6 times more for both generic and branded medicines than people living in high income countries. And we also know that for the poorest families that are paying out of pocket for hypertension, hypertension medicines can kick up at up to half of their household incomes. So when you combine this low availability with high cost of medicines, what you see is that healthcare workers are not prescribing hypertension medicines as they should, and patients are making choices to pay for other daily needs instead of paying for their hypertension medicines, given that for majority of people, hypertension is asymptomatic. So they're making choices to pay for things that are in their faces rather than pay for hypertension medicines. And this table, this data shows, buttresses the point. If you look at the last row, this is data from demonstration facilities in Nigeria. You can see that patients who are on health insurance and so are getting their medicines free of charge, their blood pressure control is 20 percentage points higher than their contemporaries who are paying for medicines. And the missed visit rate, 3 months missed visit, is about half. So what it shows us is that when patients get their medicines for free, their blood pressure control is higher, and we can retain them in care. We have a financing conundrum in hypertension medicines. Low-cost, safe, effective generics exist, and it is possible to treat patients for as little as $5 per annum. But we still have so many people who are locked out of this life-saving hypertension medicines because they cannot afford to pay. And we also see, even with the low medicine prices, countries have to increase their budget for hypertension medicine, sometimes as much as 25%, 25 times more, because of the burden, because of the scale of the condition. So we have countries, many of the LMICs that you saw on the charts that I showed earlier, they're doing a lot, they can do more, but there are also countries that will need help, solidarity, to kickstart or to accelerate progress for making life-saving hypertension medicines available at scale. So what will it take to protect 1 billion hearts, 1 billion brains, 2 billion kidneys from the complications of uncontrolled hypertension? What we need to do is to remove the biggest barrier to hypertension control at scale by making medicines available, affordable, and ideally free. So we would need high burden countries to prioritize hypertension control, not just screening, control. We would also need countries to invest more and invest efficiently so that the budgets that are available can go further. But finally, we will need key stakeholders, people sitting in this room, and including the donor community, to co-invest with countries so that we can accelerate access to hypertension medicines. With this, I'd like to say thank you for listening, and thank you for your time.
Thanks very much indeed. And I just took, there's some amazing facts there that Bolanle mentioned. The fact that people in low and middle income countries are paying more than people in high income countries for these hypertension medicines. They only necessarily cost $5 per annum. They need to be affordable, they need to be accessible, they need to be available, ideally free. So thank you very much indeed for that excellent overview. So now I want to introduce our next speaker. As Dr. Frieden has mentioned, the Republic of Korea is an outstanding success story, and I'm delighted that Dr. Hyun Kim, who's a professor in the Department of Preventive Medicine at Yonsei University, an epidemiologist by background, is going to be giving us a presentation on what has happened in the country, how they've done it. Thank you very much indeed.
Everyone. I'm Hyun Chang-kim from Yonsei University in Seoul, Korea, and it is my great honor to share the Korea's experience in hypertension control and reduction of cardiovascular disease mortality. We know that cardiovascular disease is the #1 cause of death worldwide, but recently CVD mortality has been decreased, especially in high-income country. And South Korea is one of the example, but until 1990, we suffered a very high rate of cardiovascular mortality, especially from stroke mortality. But since 1998, late 1990s, our cardiovascular mortality started to decrease very fast. And this decrease in cardiovascular mortality is parallel with improvement in hypertension control. So that will be our focus on today's my talk. But in general, worldwide, hypertension is still remains largely undertreated. Around only half are diagnosis, and 40% are treated, and just 20% are controlled. More sadly, this is the number of people with hypertension. It decreased, it doubled over the last 3 decades, but the untreated or undiagnosed hypertension indicated in orange and red color here, it is increasing in many parts of the world, and the increasing speed is very fast. So this is a paper co-authored by the researchers from university, WHO, and also Resolve to Save Lives. And this position paper proposed a global 80-80-80 BP target. It aiming that 80% of diagnosis rate and 64% of treatment rate, 51% of control rate among all hypertension people. But this target is basically based on the achievement in best performing country, including Canada, Iceland, and South Korea. The Korean Society of Hypertension, with support from Korean CDC and Korean National Health Insurance big data, annually published a fact sheet to inform both healthcare professionals and general publics about the importance of hypertension management and current situation of our hypertension. I show some of the key data. The recent data showing that 13 million Korean adults, or 30% of Korean adults, have hypertension, and among them, 11 million are under treatment, and about 8 million are on continuous medication. But sadly, the prevalence of hypertension itself did not decrease a lot. We observed a little decrease, but not so successful and not satisfactory. But on the contrary, the management of hypertension improved a lot. The recent data, the last one is year 2023, the diagnosis and treatment rate is close to 80%, and control rate is over 62%. But just 25 years ago, only 25% of our hypertensive people were treated, and the control rate is just 7%. There was big improvement over the last 25 years. But this change is mainly driven by the increased healthcare utilization. Over the last 20 years, the number of people with hypertension increased by 1.6 times. The number of people who diagnosed and treated hypertension increased about 4 times. And the most importantly, number of people on the continuous medication increased more than 13 times. So this table is from the paper published by the NCD Risk Factor Collaboration, and this paper lists the factors related to the hypertension prevention and management for each country. I wrote the section for the South Korea. But sadly, the prevalence of hypertension did not decrease a lot, so meaning that the primary prevention was not so successful. As Tom Frieden said, that our sodium intake was decreased, but during other risk factors like the physical inactivity and obesity, prevalence did not decrease a lot, but system-level intervention contributed a lot to the improvement of hypertension control. This is a summary chart of our trend in hypertension control and cardiovascular mortality in Korea. Since 1990 to to 2023, the health screening participation rate increased by 4 times, and hypertension treatment rate increased by 5 times. And as a result, average systolic blood pressure of entire hypertensive people decreased by 18 millimeter mercury, but it might be much bigger because we didn't have data before 1998. And during this time, we observed 74% decrease in age-adjusted cardiovascular mortality, and for the stroke mortality, it decreased more than 80%. And there are some very important healthcare reform. In 1989, we achieved the universal health insurance coverage. 1995, we started the national health screening program. In year 2000, we started to publish the hypertension treatment guideline. In 2009, we started community-based hypertension registration and management program. And recently in 2019, we expand the eligibility of national health screening to all people aged 20 years or older. So in summary, while the prevalence of hypertension has not declined significantly in Korea, we achieved a remarkable improvement in hypertension control. And maybe the key success factor include nationwide health screening program and universal health insurance coverage. And we also had some additional financial support for certain groups like the low-income people or older people or in people living in rural area. And continuous education of healthcare providers and also to the public can promote sustained treatment adherence. Okay, so I hope our experience can do some practical insight for other countries who are working to increase hypertension control and reduce cardiovascular mortality. Thank you for your attention.
Thank you very much indeed for that, Dr. Kim. And I remember there's going to be time for questions for Dr. Kim later on that amazing success story. And I certainly have got one, which is, what was the driver of all that? There's all the fantastic things that you've been doing, but I wonder what started it all off. But we can come to that a bit later on. So I now want to introduce the rest of our esteemed panel who are going to come up and join me. And I wonder, in the meantime, if somebody could maybe put that chair up, because I'm going to need to sit down as well. So from Ethiopia, I'm delighted that we have Dr. Mebrahtu Masebo, who is the Chief of Staff and Director General of the Office of the Minister of Health, where he leads national reform efforts and oversees major donor portfolios. Thank you. So if you'd like to come to the platform, that would be fantastic. Thank you very much indeed. We also, from Bangladesh, are delighted to welcome Professor Dr. Sayedur Rahman, Honourable Special Assistant in the Ministry of Health and Family Welfare in Bangladesh. Welcome to you. And then from Zambia, we have Mrs. Brenda Chitindi, who's a health advocate, founder and executive secretary of Zambia Health and Stroke Foundation, and a co-founder of the Zambia Non-NCD Alliance. So welcome to you, Mrs. Chitindi. Stairs, are they? Short people like me don't like these stairs. Thanks very much. And as I mentioned, as I think Dr. Frieden mentioned, we were due to have Sheikh Dr. Mohammed bin Hamad Al Thani, director of the NCD department in Qatar, but unfortunately he has had to be called away. But he did manage to create a video for us, a video message about how he's leading the effort to update Qatar's national NCD strategy with a focused subplan on cardiovascular health. So it should be on your screens now, I hope, if the technology goes right. So yes, we'll have a video from Dr. Al Thani.
Distinguished guests, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. A very good evening for all of you. It's my pleasure to be with you here today for this very important event, the side event of WHA in Geneva. I'm hoping today that we discuss how to save 1 billion lives in this issue and how Qatar has worked locally and internationally to support this. In Qatar, we are so proud about protecting from hypertension as it's a target very important to lower premature deaths of cardiovascular disease by 2030 in Qatar, part of the NCD lowering deaths by 36%. As we know all that to protect heart, especially premature, it's mainly smoking and hypertension. We are hoping here, we are proud that we could lower tobacco by 25% in Qatar for the adult and for the adolescents, at the same time by strong work about from every part collaborated in Qatar to lower this of smoking. Now we are focusing on hypertension, and we are proud to say that awareness about hypertension has grown in Qatar, and we have a screening in primary healthcare. Every person who go to screening in primary healthcare should be tested and be fine, guided by a doctor of family medicine. We have a smart well clinics in the clinics, and we have, again, we have a system to lower salt in bread in most of the industrial in Qatar by 30%, and this ended that our stepwise survey has been lowered by 33% in hypertension to become 18% in Qatari population. We are hoping now that to keep protecting this, because the risk in Qatar, we have many cases have hypertension and diabetes in the same time. Hypertension and diabetes make it very risky case, and we are trying this to lower through smart clinics and follow up in the primary healthcare. We are proud that our primary healthcare have the Diamond accreditation from Canada, and we are working to make even practicing for these people in the gym inside the primary healthcare, which we have a swimming pool and training place for people to be guided. The good thing that we are hoping now, the technology and the Internet of Things will help us to find more ways to follow people with hypertension closely in the future. We are hoping people that keep compliance on their medicine, and to find the AI to help us to find the high-risk cases as soon as possible. We are looking forward here together with you to find the most options after we did our guidelines for hypertension. With your guidance, we can have an international guidelines for hypertension to protect people with the new guidelines that happened in the last few years. On the other hand, Qatar is working domestically and regionally, internationally on different projects. For example, in Qatar, we are working to keep control on tobacco and use of the electronic cigarette. Qatar, of the rare countries in the world that's still stopping officially having electronic cigarettes. Plus, Qatar is working on lowering hypertension through the close monitoring for people and having a full registration for all the cardiac diseases and hypertension, and follow up every case on the long term. Qatar have QRDI, the Institute for Research in Qatar, and we are investing in more research in cardiovascular diseases and to understand the reason behind it. Plus, we have Qatar Public Health Institute for genomics that we test people to know the risk for them for hypertension and cardiovascular diseases, which help people to know more about the risk as soon as possible and take their case more seriously. Regionally, we are working with the region and the Gulf CCC and the IMRO to work on regional guidelines to follow up hypertension, and to work on a big campaigns through the IMRO to work about the importance of protecting yourself from the silent killer, the hypertension. Internationally, we have partners internationally to work with, like Weill Cornell in USA, and working with PHAC in Canada and others to work to understand how we can make a special research to invest in early protection and screening for cases, starting a lifestyle model for them as soon as possible. We believe in the end that hypertension is a high risk for everyone. With the way of life we are living now, people are living in a very high stressful mode and less exercise. We are hoping together we can save the 1 billion heart, inshallah, in the coming years. Thank you.
Well, thank you again to him for doing that message for us. And I think there's some common themes there that we've just heard from Korea. The use of screening, the use of training, the use of guidelines, but also some other points that he made, the use of AI and digital innovations. I think I'm going to ask our panel about that. So let me now come to our panel. I want to come to Ethiopia first. Now, you've been collaborating with Resolve. You've implemented the Ethiopian Hypertension Control Initiative. It's made blood pressure control an essential part of your national strategy to combat heart disease, I understand, and that makes it one of the most advanced in Africa. So congratulations, and I want to hear more about that. But first of all, just give a little bit of context about cardiovascular and hypertension in Ethiopia, and then the introduction and progress so far of your hypertension initiative.
Thank you so much, and good evening. I think this is a long day, but I don't see that much weak face, so at least. Thank you for having us. And as Ethiopia, one of pioneer country on disease prevention, so it's just our pioneer for the last 20 years. We are trying to focus on disease preventions, but developing countries are mainly focusing on the communicable disease. So NCD is some kind of neglected part of the national program. So with support of Resolve, we started in 2019 this program as a country to refocus on cardiovascular and NCDs, but specifically in hypertension. So we are our national program. We started with a very, very small pilot program in few facilities, and it becomes now a national program that we developed. As you know, like for developing countries, as I was very amazed by the Korean experience that has shown us how important it will help to decrease the preventable mortality. So premature mortality is one of the SDG agenda that we are working for, and also hypertension is a very known silent killer. So we really focused in our strategy to work in the blood pressure control. I think which was not in academy even when we was in the class in back days, but now we really focused on how much blood control we had. So that's programmatic interventions. And the most important thing is also availing the medicines at the forefront of the facilities. So in Ethiopia strategy, one of the focus is the essential medicine list that we worked with the Resolve program that we have, like the Director General for our Ethiopian Pharmaceutical Supply Agency, Dr. Abdu here. We have also the National Pharmaceutical Supply Lead Executive here. They can speak if you give time, but really it's one championing that we did on including in the national essential list as one of the program output. The other thing, a very important thing for us is focusing on the primary health care, because the strokes, which will cost a lot of burden outside and the dollar for you, is like in the tertiary facilities. But we need to work on the primary health care facilities to prevent, to treat as early as possible. Then the other thing very important for us is containing the cost of the medicine at the primary healthcare level. So we are enrolling the Ethiopian community-based health insurance program, which is about 62 million Ethiopians are enrolled this year. So it's mandatory. I think Dr. Abduz is a member of parliament, so they approved last year with the support that the national proclamation which enlists people in the CBH. I think I heard that from Korean experience also. Insurance is one of the program which we included. With the Korean government also, we are now expanding in the health centers on standards, on the protocols, and also the last very important thing, which was mentioned by Tom, was the digitization of the hypertension control. Like there's a very simple app which works in the 20 second. Imagine in 20 seconds you can register, then it will control the blood pressure of an individual, and it helps them to remember their appointment when they came back. And that's, I think, main achievement we had. It's a big country, we're with 140 million population, so we are starting from small, but the aim is at least to control half of the hypertension patients, and also to diagnose. That's very important in our context. You may not see that Ethiopia and then the first big countries, but it's the number that we don't have at the community level. We are working on identifying and advocating for the patients to have a diagnosis for hypertension.
And obviously you said that you started in 2019, and obviously it's now so 6 years on. Can you give us an idea of the scale of how many people you're able to reach, or the extent of the programs in primary care, how many primary care facilities, anything like any numbers you can give me?
Yeah, so like in Ethiopia, I really want to leave the number because always we argue with Tom, like there are silent people. Like, so the magnitude is so big. Even we are aiming currently to have a project with some philanthropies, some countries, to see if we can identify as many as possible people for the next 5-10 years to enroll in the medicines. But like the days attributed for NCD is 52% of the days we had. Like Ethiopia is a country with HIV, TB, malaria. These are still rampant, but NCD is coming up.
Yeah.
And the stroke level is increasing. If you can go to in every office in the ministry, like we have in every directorate, we have someone who's limping, who's passed away, like some of our young friends, like because of undiagnosed hypertension that they had. So our program is supporting many people who are not diagnosed before, and also the diagnosed one without control. And also we are working to maximize this to the highest level as we go.
And in terms of financing, so obviously Blambe was talking about the important role of actually making sure that people have got access to medicines that are affordable or free. How are you, what are you looking at in terms of additional ways of funding hypertension treatment and care aside from domestic financing?
Yeah, thank you. Thank you. That's the most important pillar, which I spoke that. So 25% of our national health account goes to hypertension and diabetic. So it's a big chunk. That's like our health account is about 3.5 billion. Then if you take, it's more than 1 billion as we speak. But as I said, we didn't diagnose. So we are trying to mobilize the CBHI, which is a local sustainable funding for hypertension medicines by insuring people. Then for transition, we need like a kind of support that now we are aiming. As I spoke, there's no many philanthropies, no many global projects which are really in country, which are in need. So we are very grateful for this resolve. Now we are approaching to some good partners to see if we can avail amyloidol, for example, in country in very low cost. So the plan is to have at least for the 5 years to supply from outside free of charge. And my minister was also part of the champions which are engaged in call for action for the 1 billion calls. And also Ethiopia has pledged to give free of charge those medications. And the government is like planning to finance 50% of the donation that we can bring from elsewhere. So we are working in advanced project to avail the medicine in country, and also we are very much willing to support at least by 50% increasing from the government treasury to support the program.
Okay, well, that's good. Thank you very much indeed for expanding on that and giving us an idea of what's been happening in Ethiopia in this area. Congratulations on the progress so far. But I want to turn to Bangladesh now, similarly working extremely hard. I mean, Professor Dr. Rahman, I mean, the burden is so high. You've got the control initiatives, I mentioned the hypertension control initiatives, the heart-based program. Medicines are being given for free, I understand, to patients, which is fantastic. Just tell us a bit more about the burden and the progress of what's happened so far.
Said, in front of this learner audience, it's really not that much important to explain the burden or magnitude of the problem. It's as usual. In our country, approximately 1/3 of the death or more than 1/3 of the death are directly related to hypertension. And approximately 18% of the disability at this life years are caused by hypertension. Moreover, premature death, that is also related to this. That is almost 43% deaths are premature related to hypertension. So the burden is much more burdened, and it's approximately, right at this moment, we have covered only 800,000 through the project that we have supported. That is the project that you have supported, that is Resolve, that only covered 800,000 till today, and that is now being escalated to around 310 centers, and that will cover around 3 million. But that will be only around 10% of the whole burden. That will, after, even in 2030, Bangladesh will be able to cover only of 10% of its hypertension burden. So we are really far behind, and the burden is really, the magnitude of the problem is huge. But even then, I greatly appreciate that through your support, our NCD of DGHS, National Heart Foundation, BRAC, and some other NGOs. They actually received support at the initiative, and that is actually a community-centered program. So that program is really giving great result. And as you already mentioned, there's a 3 to 4-fold improvement in the actually that is hypertension protection. But even then, this burden is enormous, and we have only reached a small fragment, around 2 to 3% of the whole of the burden.
And I think you've almost been a victim of your own success in a small way, because I think sometimes because there's been this increased need for medications, because you've been diagnosing people, that you've had medicine shockouts. No, I'm getting the word wrong. Stockouts. It's not shockouts. It's probably a shock when you can't get your medicine. But tell us about that, and how are you going to overcome that problem?
That is all around the world. That is a major problem for hypertension management, because that requires 365 days coverage. But fortunately, Bangladesh has got enormous pharmaceutical industry. We are one of the leading pharmaceutical manufacturers among the LDCs or LMICs. So we export to 150 countries. We cover 98% of the whole of the medication requirement, domestic requirement. So we have the capacity, but unfortunately, the state-owned manufacturing capacity, they are really right at this moment not focused on this producing this primary, that is the first-line drugs. And that is unfortunate. So we are, after, as you know, that this is an interim government. We have taken charge in last August. And then onwards, we actually redirected the production line of the industry that is named as Essential Drug Company Limited. We have redirected the production line. We're trying to cover whole of the country's requirement for first-line antihypertensive should be produced by this industry. And we expect that we can achieve that goal within 1 year. So only then actually we will be able to cover whole of the medication, at least for the 3 million in the first place in next year.
Yeah. Very ambitious.
Ambitious, but we definitely are hopeful.
Absolutely. That's good to be ambitious, as Dr. Feeden was saying earlier on. Now, obviously, your colleague from Ethiopia was talking about digital approaches, apps that can tell whether somebody, when they need to go back for the next appointment, to increase adherence. Have you been using similar digital innovation?
Yeah, Bangladesh is using digitalization, a little bit of digitalized devices is there, and that is being provided to the care provider as well as the that is the person who are really who can actually use. As a bulk of patients, they cannot actually use these devices, so it is actually provided to the provider first, and they're connecting to through mobile phone and other devices. So it is being digitalized and monitored. The service is being monitored, and it is trying to, that is so that they're not dropped out. So that is our effort right at this moment, and that has improved a lot actually. Now it has, as you said, it was previously, it was only 14% of the people were covered. Now it is around 55 to 60% of the person are really covered. That is, the hypertension is under control. So digitalization has actually contributed a lot in our program that is supported by Resolve.
Right. And obviously I've got to return to the important topic of financing. What's your government doing to increase financing? You talk about you have an interim government at the moment, but in terms of access to hypertension medicines, what's the plan there?
Okay. Actually, as you are providing the free of cost, actually the interim government is trying to provide expansion of this program. The plan of the interim government is to provide all of the essential medicine free of cost to the whole of the population. That is the target for next 5 years. And definitely in the core is anti-diabetic and antihypertensive. So that actually there will be enormous escalation in the budgetary allocation on medicine. And that is for procurement as well as for the capacity building of the producing. So this will be two areas. But the major barrier is, though, right at this moment, the domestic production cost is higher than the actually regional median price. So we need to address that, and we need to improve the efficiency as well. So, but the financial mechanism, in addition, I just want to mention that we just have received No Tobacco Day Award, right? This from the World Health Assembly. We're actually focusing on some other issues as well, like high tax on tobacco. We're actually, there's a label change in all of the products, that is packaged products containing salt. They need to declare under hazard related to salt. And in addition, actually, we are also trying to introduce actually low sodium salt into market. So there are a couple of other interventions are also our government are considering to adopt.
Thank you very much indeed. Well, let me pass to Zambia, Mrs. Chidindi, in terms of the patient perspective, which is really important, and I'm really pleased that you're here to talk to us about it. I mean, obviously, we've heard what's been happening in these other countries where progress is being made. Oh, don't worry, we don't have to leave yet. My alarm's not going off. So what is happening in terms of your personal story, living with multiple NCDs? If you could just paint a little picture of your life and how you've been affected by access to medication and lack of access to health insurance programs potentially. I think it should be on.
Thank you very much. Good afternoon. First of all, I have to clarify the organizations that you've seen here. My father was a chain smoker and he died of prostate cancer. Then I formed an organization, Tobacco Free Association of Zambia, to tackle the tobacco control issues. Then my mother died of a heart issue. Then I formed an organization again, Zambia Heart and Stroke Foundation, so that I can advocate for other people not to be affected. And I've been living with the high blood pressure, hypertensive, as you call it, for this is almost the third decade, almost 30 years. And it hasn't been easy. It hasn't been easy. Because first what I noticed was I used to get very hot in the night. And I used to tell my children to pour me water. I would lie, then pour me water, cold water. Then after it continued, then I went to the hospital. Then they told me, no. You've been giving yourself a wrong medication, that was water. Then they gave me they put me on medication. The first medication, I couldn't, it was so strong for me and I couldn't continue. Then the third one, I couldn't continue also until the third one. That's the one I'm still using up to now. And we can only talk about hypertension, but when you have it, it's something else. It's not easy. It's very, I would say, very oppressing. Even your thinking capacity is not all that good or straight. And through these medications that I've been getting, I've developed other ailments like numbness on my left-hand side, or the left side of the body. I get numbness, and then arthritis, and then obesity. Because of the daily medication, taking medication. So life has not been, no, it's not easy.
So 30 years is a very long time.
Not easy.
Tell me, I mean, how have you managed to pay for the medications that you've needed over such a long period of time?
Yeah, the time I was first diagnosed with high blood pressure, by then I wasn't working. My children used to buy for me every time. They used to buy me every time because I have 5 children. So they used to exchange. This one buys this month, then the other one, so just like that. Until when the Zambian government introduced the National Health Scheme, where we were very lucky and we were told to be getting free medication. And we took those medications free of charge. But of late again, due to the political system, change of political system again, it has affected us. What they do now, the cheaper medication, they give us free, But the expensive one, we are told to buy. So it's real very, very.
Even with the health insurance, you still have to pay for the more expensive one. And presumably that is out of bounds. That's not possible for many, many people who you know.
Yeah, it's not, everyone cannot afford, and especially rural areas, they cannot afford or they cannot access to clinics, because also on the part of clinics and the specialists, you just find them in the urban areas, and the rural areas, they have no access. So people just die without without getting to health centers.
Well, I think that's a very powerful testimony on the impact of not having the treatment that you need, and which is obviously what we've been talking about, the need to get this universally available to help people and save lives. So thank you very much indeed, Mr. Chatindi, for those remarks. I want to open to the floor now. So your chance to answer put some questions to any of our panel, including Dr. Kim from Kenya. So please do put your hand up. There's roving mics. Tell me where you're from and give me your question. So the nice lady help me with a chair. Got over in the front over here. Thank you.
I would have a question for you, if that's okay. So my name is Alev Mine. I run the One Goal Initiative for Governance. The question is the following. The ideal blood pressure rises with age in order to enable proper irrigation to be continued. So how is that taken into consideration in the plans and programs?
Tom, shall I give you a microphone?
I'll start and then Dr. Kim
can
continue. I'm really glad you asked, because it's a common misconception. If you look at pre-industrial societies, there was no age-related increase in blood pressure. 90 over 60 at age 16, 90 over 60 at age 60. And their sodium consumption is about 1/10 of ours. Many things that we're taught are age-related are not. They are toxicity related. We are being pickled in salt, basically. And the concept that it's normal to have an increase in blood pressure is just, we were taught it in medical school. I was in a country I won't name, where a very important person running a very large program told me, yes, it's 10 points every decade. No, this may happen, but what's really clear, beyond a shadow of a doubt, brilliant studies from Oxford in multiple countries showed that starting at 115 over 75, every 20-point increase in blood pressure doubles your cardiovascular risk of death between ages 30 and 69. So if you go to the doctor and your blood pressure is 128 over 80 and they say, great, they're wrong. My doctors say that all the time. I say, you're wrong. The next big piece of evidence came from the SPRINT trial, replicated clearly, and it was that if you bring it down to 120 over 80 as a target, your risk of death is 27% lower than at 140 over 90. Just last month, new data from China showed that if you aim for 130 over 80, you have a big reduction in the risk of dementia. So lower is better. There's nothing normal about the age-related increase in blood pressure. It's true, it happens in our society, but it's not part of our normal physiology. It's part of our toxic environment, especially too much sodium and too little potassium. But I'm so glad you asked, because it's one of the things that really undermines our ability to treat. We have therapeutic inertia all over the world. Patients come in at 143, doctors, I'll come back in a month. They don't come back, they stop medicines. And if you get the patient below, if your target is 140, you go down to 130, you're doing them a favor. The diabetes societies all say aim for 130 for people with diabetes. But Dr. Kim, you are better able to say this than I am.
I totally agree with you that that is the one reason it is very important to continue education of not only the general public but also the medical doctors. Even some doctors, yeah, as he said, that some patients have systolic blood pressure about 150 or 160. The doctor can say that considering your age, it is not so high. Just keep healthy, but it's not true. So we have to educate the doctors about the new treatment guideline and new evidence. But we know that, but we have a continuing medical education program, but many doctors want to study about something very new techniques or new drugs, and they don't care about the hypertension management because they think that it's very easy, and they don't need new evidence. So I, for that reason, the professional academic society is very important. The Korean Society of Hypertension started 30 years ago, so we try to make more educational session for the primary care physicians and public specialists about the new evidence and there is a huge amount of evidence that lower blood pressure is much as much importance as not only in younger generation but older generation. And in Korea, the biggest success was decreasing stroke mortality. But stroke is commonly occurs in very elderly people, age 60, 70, or 80s, without the hypertension control in the elderly population. We did not observe such a big some reduction in cardiovascular mortality.
Thank you very much indeed. Okay, let's come back to the financing medication for hypertension. I've got a question here in third row back, please. Yes, sir.
Let me stand. I'm told it's good for your health. Yeah, my name is Elijah Ogola. I'm from Kenya, and I'm the president of the Pan-African Society of Cardiology. Mine is more of a comment. First, let me start by congratulating Resolve to Save Lives for the great work they are doing and for organizing this. I actually had not intended to come for this meeting, but she's a very persuasive lady, so she twisted my arms and I came. My comment is that I look at the protocol, as it were, for lack of a better word, of the Resolve to Save Lives in terms of control of hypertension. And it starts at the point at which you've diagnosed hypertension. So it's essentially aimed at controlling the person who already know that they have hypertension, which is, of course, an extremely important thing. There's no point making a diagnosis if you're not going to control. But I just want to highlight the fact that in many parts of the world, especially the part of the world where I come from, knowing that you have hypertension itself might be self-evident but does not occur.
Yeah.
Data in Kenya, for example, we have is like just about 15% of the population know that they have hypertension.
Yeah.
And this is largely due to the fact that the majority of the adult population, despite getting to health facilities, have never had a single blood pressure measurement in their lives. So what I'm saying is that this has to be incorporated into the process, especially by teaching or training healthcare workers.
Okay.
Because people get in touch with the healthcare system, but they don't have their blood pressure measured.
Let me put that to Dr. Muratu and to Dr. Sethuraman. What are your comments on that? I mean, how can we increase more people to get tested in the first place and diagnosed? Is that the big problem here?
Thank you. I think this is very, very well noted from my colleague from Kenya, and congratulations for being here with us today. So, especially in Africa, it's not usually, if you don't feel in your personal body that you are sick, so you will not go to the facilities. So we have people who never visited for facility for years. That's the custom, I think. So if you are also ill but with little bit, then you just defer to take something in at home. But in the hypertension, you may not have any symptoms, like something you can recognize. So there are so many people who are not registered any blood pressure in their life. That's one thing, as I said. The diagnosis is very less. When we started even the control, it was 2.5%. I didn't want to go the numbers because it's very, very low. It cannot be comparable with any of the world countries. So, but for us, the most important thing is prevention, as we said, and at the primary healthcare level, where the societies are. And like the government is taking now initiative to have a bike. I like Tom whenever he has a bike, but there is no biking line in capital city so far. We started last year as a program. Then there is a working way that the government is now working in every cities to give a life balance. So the Africans, like our ancestors, they are farmers. They are very strong, but they are working there. They are doing very physical activities. But nowadays, because of the food change, because of the cell change that we are working with the parliament to change the cell,
Yeah.
there are so many comprehensive things to work in the preventions. But diagnosing as early as possible is the best instrument we can prescribe. Thank you.
Thank you. Dr. Ram, do you want to have a brief addition to that?
Yeah. Actually, non-physician involvement in screening mechanism, that actually resulted in number of detection is increased detection.
Yeah.
And in our context, actually, the involvement of the non-physician for screening and then sending them to the physician in the primary care facilities. So that is the actually most appropriate way so far we understood to diagnose and detect more.
Yeah.
And gradually reducing the age limit according to the capacity or enhancement. That could be a good balance between these two.
Thank you, Dr. Ram. I've got a question here, the chap in the third row. Oh, sorry, yes, Mr. Chitindi.
I think we lack healthy promotion in the community because most people don't know anything. So I think community outreach and sensitize the people and do the health promotion, it can help a lot because people will know exactly what's happening.
And you can get a lot of bang for your buck in terms of health promotion, can't you? It's not that expensive to do it. It's getting community health workers, volunteers to get that message across is very effective, I understand.
Yes.
Yeah. Okay, you've been very patient. Let me come to you now for your question.
Salim Salama, I'm the CEO of WISH, the World Innovation Summit for Health with Qatar Foundation. I spent 11 years of my life with WHO on the hearts and the implementation in countries. And one thing that I noticed also in the slide from our colleague from Korea, in the early milestone that you mentioned was the insurance scheme or the support. And what we see in countries is that we can change aspect about how we standardize care, how we simplify it, access to medicine, but there are sector reform that need to accompany, and financing is one of them. How we change access to increase coverage is one aspect. How we mobilize intersectoral action for the preventive part are wide, sector-wide changes. How have you been accompanying this? Because often as clinicians or healthcare professionals, we can address the service delivery aspect. With the broader sector reform, how in Korea, for instance, that milestone, you have incorporated it into the service delivery. And the second, perhaps, if I may, we have more than 17 million people mostly displaced in the world, and we have someone from Bangladesh, and Bangladesh has a lot to say on how you have expanded the benefit package that was developed for the host community to the Rohingya refugee in the Cox's Bazar. I wanted perhaps to elaborate on the challenges, but also I think on that exemplary, illustration of how people that can benefit also that are the most vulnerable and the refugee population from some of those examples of how host communities benefit, but also models that work for the host community should benefit also the ones that are on the move.
Okay, thank you. Now we've only got a couple of minutes left, so I will take brief answers on these. So, Dr. Kim, first of all, how did the health insurance come about? And also, the question I mentioned earlier about the drivers for all of this to happen. What was the motivation? Was there one individual who was really, fervent about hypertension?
Yeah, it is very hard to answer the question because we did many things over the last 2 or 3 decades. And actually, our top priority was not the hypertension control in our government, but very luckily, we did many things which actually works for the better hypertension control. For example, the insurance coverage, we achieved 100% of coverage in 1989. So there is no more some financial barrier. And but we have some co-payment system, but even the small amount of co-payment can be a barrier for some people. So we have a free the system for low-income people, and for elderly, we had some very limited co-payment. It's just $1 US. And we started the National Health Screening Program because in the past, as a developing country, South Korea suffered from the infectious disease and then tuberculosis. We did a national survey for tuberculosis or some infectious disease, and we changed it to the health screening program. But compared to other chronic condition, the hypertension, once diagnosed, once started medication, it is well controlled compared to other condition. And that is the main reason for the screening is more important for hypertension. And we have one very important strategy to increase the screening participation rate. We calculate the participation rate for each company, and the company's participation rate is lower than average or lower than 90%, we get some penalty to the company.
Right.
At year end, the company leaderships are checking who are screened or who are not screened, and they email or make a phone call to take the health screening. That is one of the reason secret for our.
Okay. Thank you. I can see that the catering staff are keen to get out and they're making lots of noise. So apologies for that. But a quick answer to Dr. Rahman about the host communities.
Actually, that's a crucial question for our, that is forcefully displaced by national. That's a really 1.2 billion right at this moment, and still it's continuing. So it's a great pressure on our host community. But as the support from different organizations for decades actually are drained on that part, particularly in a particular region, that has got a trickle-down influence, and there are certain targeted effects as well. So there are certain targeted programs for our host community, and there's certain trickle-down effect of that particular support that are being provided to the FDMNs. So, but on this hypertension, it's easy to administer the activity in that particular region. That's great. That appears sounds well, but at the end of the day, actually, that's not actually sustainable because of they are not actually their educational and the other aspect of nutritional and other aspects, and their non-adherence. As you know that the FDMN, they are really disturbed mentally, so they are actually not that much adherent to the program. So that is a kind of thing, a mixed kind of thing. So FDMNs, their program is successful apparently. They're not adhering to, and the support to the host community, that is, there are certain targeted programs, but that on most occasions, that is not exactly sufficient to cover the host community. And right at this moment, because of these fund crash from different sources, they're actually withdrawing the fund, and FDMN is suffering a lot.
Okay, thank you, Dr. Rahman. I think we're going to have to wrap it up, but thank you. Our panelists will remain here for the networking, so thank you very much indeed to all four for contributing to our discussion. I'm just going to invite Professor Narula to come to the podium to give some closing remarks, President of the World Heart Federation. Thank you very much indeed, and thank you for your patience.
Before I say anything, I tell you that the question that was asked, first question that was asked, probably was the most valuable question of this session. And the way Dr. Frieden and Dr. Kim answered, it was amazing. And I cannot resist adding 3 sentences in favor of that. The first, that this misconception that it increases with age, it has come from our epidemiological studies when we had done them. So, what we have measured in our epidemiological studies and what values we have gotten, whether it is for blood pressure or that is for cholesterol, that is the usual value. It is not the normal value. It is the usual value of the population that is at a high risk of dying of a vascular death. That's one. Second important thing which Dr. Frieden said, which one must remember, and that is that it is always this modest elevation of multiple risk factors, which is much worse than even an extreme elevation of one risk factor. And third important thing, as we have always said, that these risk factors increase with age. So age has become the worst risk factor. But age is not a risk factor. Age is a representation of the length of exposure to the risk factors. So we must take care of these risk factors. So thank you, Dr. Frieden, and thank you, Dr. Kim, for making those valuable comments. And thank you very much for asking that question. I'm so glad you asked that. So, good evening to you. It has been a great privilege to be with you for what has been an inspiring and action-oriented discussion. I want to thank all our speakers, panelists, and even every one of you, whether here in Geneva or some people who have joined us virtually, for your commitment to protecting 1 billion hearts. And for a New Yorker, it is obviously an honor to be working alongside Tom Frieden. We sincerely thank Resolve to Save Lives for their long-standing commitment to improving hypertension control worldwide, for keeping this leading risk factor for cardiovascular disease high on the global health agenda, and for sponsoring the organization of this event. What we have heard this evening is both a call to urgency and message of possibility. We have seen how countries like Republic of Korea have transformed hypertension control into a public health success story. We have heard from leaders in Ethiopia, Bangladesh, and Qatar who are not just diagnosing the problem, but designing and delivering solutions. And we have been powerfully reminded by Brenda Chitindi of what is at stake when access to essential medicines remains out of reach, lives interrupted, families burdened, and futures cut short. At the World Heart Federation, we believe that universal access to affordable, quality-assured hypertension treatment is not just a clinical imperative, it is a moral one. This is why we have set an ambitious but achievable goal to help expand treatment to 500 million more people by 2030. We cannot do this alone. Achieving this target demands bold partnerships, sustaining financing mechanisms, stronger national commitments, and a focus on equitable access. That is why today's global call to action to reach 50% blood pressure control by 2030 is so timely. It aligns not only with our scientific understanding of what works, but with our shared vision for a healthier, more just world. So let me end by saying we need to move forward not with incremental change, but with collective resolve. Let us support each other, governments, civil society, funders, and patients alike, in translating words into action, policies into access, and ambition into the lives saved. We can and we must protect 1 billion hearts. Thank you, Dr. Frieden, once again.
Thanks so very much, Professor Narula, for that eloquent summing up of the event. And absolutely, I echo that about joining that campaign to protect 1 billion hearts. We've come to the end of our session. The people who are here in Geneva, there is a reception just here in this room. You can take your drinks outside if you wish. And so, yes, please do stay until 8 o'clock. For our panelists, they've got one last task, which is a group photo. So please do stay. We're not going to get away with that. But yes, let's hope we can get to 1,000 signatures before the UN General Assembly for the call to action that Professor Narula has just mentioned. So thank you very much indeed for attending. It's been a great conversation, great speeches. Thank you.